Today's the topic of my lecture is AUB, is nothing but the abnormal uterine bleeding. In the outline of today's lecture, we'll discuss about some terms and the definitions of the AUB, the classification, the newer classification of the AUB, which is called as the PALM-COEIN classification, the terms which are historically used and the newer terms and the discarded terms. We'll discuss about all these things. But before that, I would like to tell you something about the normal menstrual cycle. Every patient which comes to the gynec OPD, we must take a detailed menstrual history of that patient during examination, before examination. In that menstrual history, we must ask about how many days the patient is bleed, whether the menstruation is regular or not, if the flow of the menstruation is a normal or abnormal, and whether it is a painless or a painful menstruation in that patient. In normal menstruation, the duration of the cycle is around about 2 to 8 days. The amount of the bleeding is 35 to 50 ml of the blood per day. And the regular menses means the menses comes after every 21 to 35 days. It is called as a normal menstruation. Now there are some terminologies related to the menstrual cycle. The first term is amenorrhea, which indicates that there is an absence of the menstruation at least for 6 months in a secondary amenorrhea. The oligomenorrhea, here there is an infrequent and irregularly timed episode of the bleeding, which usually occurs at an interval of more than 35 days. So it is called as oligomenorrhea, where the menses come late. The polymenorrhea, it denotes a frequent episode of the menstruation, which usually occurs at the interval of the 21 days or less. The menorrhagia denotes a regularly timed episode of the bleeding that are excessive in amount or in a duration of the period. If the patient bleeds more than 80 ml per day or she bleeds for more than 5 days, it is called as a menorrhagia. And hypomenorrhea refers to the regularity time but a scanty episodes of the bleeding, which usually occurs in Asherman syndrome. So this terminology is depend upon the amount of the bleeding which patients give history-wise. Now the next terminology is the metrorrhagia, which refers to the irregularly timed episodes of the bleeding, which is superimposed on the normal cyclical bleeding. A menometrorrhagia means excessive and a prolonged bleeding that occurs at the irregularly timed and a frequent interval. The next terminology is the postcoital bleeding that denotes a vaginal bleeding after a sexual intercourse. It is usually seen in the cases where there is a cervical growth is present. And the next terminology is a DUB, that is a dysfunctional uterine bleeding. Here, the abnormal heavy menstrual bleeding when no structural genital tract abnormality or a genital cause was detected in a woman of a reproductive age in the absence of the pregnancy. The DUB is an old terminology where there is no structural abnormalities are found. So all these terminologies except amenorrhea are discarded in a newer gynecology. Only the amenorrhea term is retained. So what are the new terms? Now the new term is AUB. It is a abnormal uterine bleeding, where the menstrual bleeding abnormal in a regularity, volume, frequency or a duration in absence of the pregnancy. Or the second term is a heavy menstrual bleeding. Here, there is excessive menstrual blood loss which interfere with the woman's physical, social, emotional and or marital quality of the life. These are the two new terms. In these terms, there is an acute AUB and a chronic AUB. A chronic AUB is a bleeding from the uterus in abnormal in a duration, volume, frequency and or a regularity which is present more than 6 months. Or it may be the acute AUB, where the episodes of the heavy bleeding, in the opinion of the clinician, is of a sufficient quantity to require immediate intervention to minimize or prevent further blood loss. The acute AUB may be de novo or it may be superimposed to the chronic AUB. The next new term is intermenstrual bleeding. Here, there is a spontaneous bleeding occurring between the regular menstrual period. It may be cyclical, where the bleeding may be in an early period of the menstruation, mid period or a late cycle, or it may be a random. Now, if there is a problem in the frequency of the menstrual blood loss, it may be divided as absent when it is called as amenorrhea. The patient may be having a normal menstrual bleeding. It may be infrequent or frequent. In infrequent, the cycle comes after every 35 days or more, and a frequent menses means it comes before 21 weeks, 21 days of the menstruation. We can classify the AUB accordingly the duration of the bleeding. It is called as a normal if the bleeding is less than for 8 days, or it is called as a prolonged if it is more than 8 days. Whether it is a regular or not regular or irregular. If it is a regular, it comes after every month. If it is irregular, it comes after the 35 days of the menstrual cycle. We can divide or classify AUB according to the flow volume as of light, normal or heavy bleeding. Now, broadly, the AUB is classified as a adolescent AUB, reproductive age group AUB, a perimenopausal AUB and a postmenopausal AUB. The postmenopausal is totally different because the causes of the postmenopausal bleedings are different. The common cause of the postmenopausal bleeding in India is a CA cervix, but worldwide it is a senile endometritis. In some cases, the postmenopausal bleeding may be because of the endometrial hyperplasia in 5 to 10% of the cases, or it may be because of the CA endometrium in 10% of the cases. The adolescent and the perimenopausal AUB is totally different because it is usually because of the anovulation. The anovulation is very common in this period of the life. So today we are going to elaborate the AUB in a reproductive age group. The reproductive age group is classified. The AUB in a reproductive age group is classified as a PALM-COEIN classification. Here, the PALM means polyp, adenomyosis, leiomyoma, or a malignancy, and COEIN means coagulopathy, ovulatory dysfunction, endometrial cause, iatrogenic cause, or some causes are not yet classified. Today, we will discuss about the PALM. So the first part of the PALM is a AUBP, means polyp. What is polyp? It is a localized tumor of the columnar epithelium of the endocervix or endometrial epithelium, which contains both the glandular and stromal elements. The polyp is usually benign. It is estrogen dependent. The prevalence of the polyp is around about 10 to 15%, and it is a very common in a reproductive age group. You can see here, this is the polyp which is growing to the endometrial cavity and it is coming out to the cervix. So the patient usually comes with complaints of the intermenstrual bleeding or a bloody discharge. The menstrual cycle is a normal. There is no problem with the menstrual cycle, but there is a intermenstrual bleeding and a bloody discharge. We can diagnose the polyp by doing a simple pore speculum examination if that polyp is coming out of the cervix. If it is not coming out of the cervix, we can diagnose it by doing a ultrasonography, which is the easiest way to diagnose the polyp, or we can use a SIS, that is a saline infused sonography, or a cystoscopy is the best as a diagnostic as well as a therapeutic. On ultrasound, we can see that there is a which is going very well. At the same time, there is a polyp can be seen in the cervical region. When we apply a Doppler over here, we can see some vessel feeding to that polyp. So the vascular is not much, but only vessel which is supplying to that polyp we can see on a Doppler. So what is the treatment of the polypectomy? If that polyp is coming out of the cervix, we can remove by this. One is polypectomy forceps. We can catch hold the polyp which is coming out of the cervix by this forceps. We will twist it and we can remove it and send for the histopathology. But if it is an intrauterine cavity, we can use the histoscope, which is having a sneer with a wire. We can apply this wire surrounding the stalk of the polyp. We can entangle it and we can remove that polyp and send for the histopathology. The next group is the AUB-A, that is nothing but the adenomyosis. So what is the adenomyosis exactly? It is nothing but the endometriosis of the uterus. Here, the patient, suppose she is a 40 to 42 years multigravida, came with the complaints usually with a heavy menstrual bleeding she bleeds for at least 6 to 7 days, and there is a pain during the menstruation. So dysmenorrhea is a common symptom in a adenomyosis. What is exactly adenomyosis? It is an endometrial tissue present in the myometrium at least 2.5 millimeter beyond the endomyometrial junction. Because of this, there is a smooth muscle hyperplasia takes place, and it is a 100% estrogen dependent entity. So it is a very common in a reproductive age group. Here, the patient presents with the heavy menstrual bleeding, dysmenorrhea. Patient may complain of the chronic pelvic pain. The uterus is enlarged in an anterior-posterior direction, but the enlargement of the uterus that is not much. It is rarely more than twice of its normal size. When we do the per-vaginal examination, we can find that the uterus is firm and it is tender. To confirm our diagnosis, we can do the ultrasonography, or 100% for confirmation, we can use the MRI. There are some specific pictures we can see on ultrasound. On ultrasound, we can see that there is a inhomogeneous myometrium. The uterus has become globular. There are cystic spaces can be seen in the myometrium, and the border of the endometrium and the myometrium is become indistinct. When we apply Doppler on the case of the adenomyosis, we can see the pool of the blood vessels surrounding the lesion. This is the confirmatory diagnosis of the adenomyosis. These are some pictures which are suggestive of the adenomyosis. The uterus become globular. There is an asymmetrical thickening of the uterus. There are some cysts can be seen in the myometrium. There is a hyperechoic island can be seen. There is a echogenic subendometrial lines or buds because of the invasion of the myometrium and endometrium can be seen. And when we apply the Doppler, we can see the translesional vascularity which is increased in the cases of the adenomyosis. For the management of the adenomyosis, there are a medical or a surgical management, but the patient does not respond well to the medical management. But we can try in some cases a GnRH analog, progesterone, or a OC pills in some patients. But the definitive management for the adenomyosis is a surgical. If the patient is interested in a continuation of the fertility, we can do the adenomyoectomy where we can remove the diseased myometrium. Or if the patient has completed her family and the bleeding is severe, then we can go for the hysterectomy. That is the best treatment. The next point in the classification is AUBL, that is a leiomyoma. It is the most common pelvic tumor in a female. It is a benign fibromuscular tumor of the myometrium. It is estrogen and progesterone dependent. Because of that, it is a very common in a reproductive age group of the patient. We can subclassify the uterine fibroid as a submucous, intramural, or subserous. In AUB, we consider usually the submucous or intramyometrial because they increases the blood loss during the menstrual cycle. Clinically, the patients present, mostly the patient is asymptomatic in 50 to 60% of the cases. We do the ultrasound for some other reason and we can find that there is a fibroid to the uterus. If the patient is asymptomatic, the first and most common presentation is a AUB or a heavy menstrual bleeding. It is usually present in a submucous or intramural fibroid. The bleeding is increased because of there is an increase in the surface area of the endometrium. There is a disturbed uterine contraction because of the presence of the fibroid in the uterus. At the same time, there is a dysregulation of the prostaglandin synthesis in the cases of the fibroid with the uterus. So there is an excessive bleeding. If the fibroid is a subserous, there are some pressure symptoms the patient can be present with, or in some patient there is a reproductive issue like a recurrent pregnancy losses or infertility in the cases of the fibroid. We can finalize our diagnosis by doing the ultrasonography. We can see easily on ultrasound the hypoechoic, well-defined and rounded mass in a myometrium. Or if needed, we can do a saline-infused sonography or hysteroscopy to confirm our diagnosis. And the 100% diagnosis can be done by using the MRI. In the management of the fibroid, there are expectant medical or surgical managements are there. If the patient is asymptomatic and nearing menopause, we can do expectant management to prevent the anemia. If patient goes in a menopause, in most of the cases, the size of the fibroid is reduces. In 1% of the cases, yes, there are chances of the malignancy conversion. We can try a medical management if the fibroids are small. We can use a NSAID, tranexamic acid, OC pills, progesterone, or a uniprostone to reduce the bleeding. At the same time, we can reduce the size of the fibroid, but this is not the definitive treatment. Once we stop the treatment, the size of the fibroid, at the same time the symptoms are increased. So the definitive treatment is a surgical again. If the patient wants the continuation of the fertility, we can do the myomectomy in that cases, or if the patient is nearing the menopause or perimenopausal, but with having a severe bleeding, we can do a hysterectomy for the uterine fibroids. The next classification is the AUB, means hyperplasia or a malignancy. In this case, there is a history of the chronic anovulation. Because of the chronic anovulation, there is a continuous supply of the estrogen. Because of that, there is an increase in the size of the endometrium. Once this endometrium runs out of the blood supply, there is a bleeding of that endometrium because of the shedding. So here, the irregular proliferation of the endometrial glands with an increase in the glands to stroma ratio when compared with the proliferative endometrium. The endometrium hyperplasia can be divided as a simple or a complex. In a simple hyperplasia, there is a thickening of the endometrium, but in a complex, there are chances that the patient may show some atypia in the hyperplasic endometrium. This complex hyperplasia is nothing but the precursor of the type 1 endometrial malignancy if we didn't treat them. It is very important to see whether the hyperplasia is without atypia or with atypia, because if there is atypia without atypia, hyperplasia without atypia, the coexistent C endometrium is only less than 1%, and the conversion rate is also very low. It is a 1.1, not 1 to 1.03. But if there is a associated atypia, the coexistent C endometrium chances is 25 to 33%, and the conversion rate is 14 to 45% from atypia to the malignancy. So it is very important to treat the patient of the hyperplasia in a perimenopausal age group. If we send that material which is taken from the endometrium, we can see that if it is nothing is there, it is normal. But if there is a simple hyperplasia or a complex hyperplasia, in a complex there is a decreased stroma, the glands are increased in the number, there are back-to-back arrangement of the glands are there, and the ratio of the nucleus and the cytoplasm in the cellular part is disturbed. So it is a chances of the atypia is always there. So we are supposed to do the endometrial biopsy and send it for the histopathology in a patient of the endometrial hyperplasia. We can diagnose it by doing the ultrasound and doing a people's biopsy, and we send that for the histopathology. In a perimenopausal patient, if the thickness is more than the endometrial thickness is more than 12 millimeter, it is abnormal. But if the patient is a menopausal, in that case, if the thickness of the endometrium is more than 6 millimeter, it is abnormal. In that cases, we are supposed to take the biopsy of the endometrium by peoples, and we send the endometrium for the histopathology. Once we send it for the histopathology, the diagnosis may be the hyperplasia without atypia or atypical hyperplasia. If the report comes as a without atypia, we can use the Leiomyoma intrauterine devices, which has contained like a Mirena, which contains around about 52 milligram of the progesterone and releases a 20 microgram of the progesterone daily, so that the hyperplasia is reduces, the endometrium becomes normal, and it can work for the 5 years. But if there is atypical hyperplasia and the patient has completed her family, we can go for the hysterectomy. But if there is atypical hyperplasia and the patient wants to retain her fertility, we can try with a Mirena again, or we can start a long-term oral continuous progesterone to reduce the size of the hyperplasia of the endometrium, and we can try for the pregnancy once she confirms that the endometrial size is reduced. Thank you.